Welcome to the Deep Dive. Today we are focusing on a technology that sits right at the intersection of reproductive medicine and cutting-edge genomics, preimplantation genetic testing. We're talking about testing an embryo, figuring out its genetic blueprint before it's even transferred for pregnancy.
Exactly. We call it PGT. And really, it represents one of the most, let's say, proactive steps available to prevent certain birth defects or understand why pregnancies might be failing early on. It basically merges complex genetic analysis right into the IVF process, assisted reproductive technology or RT.
Okay, let's unpack this. I think it helps to start with the three main categories you'll see mentioned. What are they?
Right. The classifications, they're based entirely on what the test is looking for. So first, there's PGT-M. That M is for monogenic diseases. These are the single gene disorders. Think cystic fibrosis, maybe Huntington's, sickle cell anemia, things like that.
Got it. Single gene defects.
Then you have PGT-SR. The SR stands for structural rearrangements. This is for cases where one or both parents might carry something like a balanced translocation or an inversion in their chromosomes. These often don't affect the parent, but they can cause problems like infertility or recurrent miscarriages.
Okay, and the third?
And finally, the one we hear about most often, PGT-A. The A is for aneuploidies. This test essentially just checks if the embryo has the correct number of chromosomes, too many or too few.
Right. And here's where we hit the sort of central tension right away, isn't it? For couples who know they carry a specific risk, like for PGT-M or PGT-SR, those tests seem pretty established and effective tools.
That's generally true. Their value isn't really up for major debate in those specific situations. The PGT-A, the one screening broadly for chromosome numbers, that one is still incredibly controversial. There are significant technical hurdles and honestly ongoing debates about whether it actually improves the overall chance of having a baby for everyone using IVF.
Okay, so let's dive into the tech itself. Maybe start at the very beginning. The first challenge that applies to all types of PGT. We're dealing with just minuscule amounts of DNA, right?
Oh, absolutely minuscule. The entire test relies on a tiny sample from what's called a blastocyst biopsy, usually just 5, maybe 10 cells. Taken from the trophectoderm, that's the part that will eventually form the placenta.
5 to 10 cells, that's it.
That's it. And that's nowhere near enough DNA to run the kinds of genetic analyses needed. So the first critical step in the lab is whole genome amplification, or WGA.
WGA. Okay. Amplification means making copies, right?
Exactly. It's a process to generate thousands, even millions of copies of that very limited starting DNA template.
That sounds, I don't know, like making copies of a copy on a microscopic scale. Are there risks? Does it distort the original information?
There's a major inherent risk. WGA introduces something called allele dropout, or ADO. You could almost call it the silent killer of accuracy in PGT.
Allele dropout, what does that mean exactly?
Okay, so remember, we inherit 2 copies of most genes, one from each parent. These copies are called alleles. ADO is when, during that amplification process, one of those 2 alleles in the sample just fails to amplify properly. Or it gets amplified so poorly, it's basically undetected.
So one version of the gene just disappears from the results.
Pretty much. And you can see why this is particularly dangerous for PGT-M, right?
Yeah, absolutely. If you're testing for a serious single gene disorder?
Exactly. Say you're looking for a specific pathogenic variant, the bad copy of the gene. If that allele drops out during WGA,
The test misses it.
it reports a false negative. The embryo looks genetically normal, but it actually carries the disease mutation. So the couple might be told their embryo is healthy, transfer it, only to find out later the test failed because of ADO. It's not just a technical glitch, it's a potential life-altering misdiagnosis. That risk really drives a lot of the follow-up techniques.
Wow. Okay, besides the amplification challenge, what other technical limits does PGT face?
Another big one is the resolution limit. Even with modern sequencing and array technologies, it's still difficult to reliably detect very small changes in chromosome structure. We're talking about small fragment copy number variations, or CNVs. Anything smaller than about 1 megabase that's a million DNA base pairs can be tough to identify accurately.
And that impacts PGT-SR, right? Finding those subtle structural rearrangements.
Precisely, especially the cryptic ones, the really small translocations or deletions that standard tests might miss.
But this is where things are getting really interesting, you mentioned. The technology is improving for finding these tricky rearrangements, especially in the parents beforehand.
Yes, definitely. Our ability to find these complex structural issues in prospective parents, the ones causing recurrent losses or infertility, it's advancing rapidly. Think about traditional karyotyping, just looking at chromosomes under a microscope. It often fails if the rearranged fragments are smaller than, say, 5 megabases, so carriers could go undiagnosed for years.
So what's changing that?
Well, now we have newer methods like optical genome mapping or OGM. It's a completely different approach. Instead of just a blurry picture, OGM acts like an ultra-high resolution structural scan for the DNA itself. It can spot tiny breaks, rearrangements down to just a few hundred base pairs, things that were completely invisible before. It's like having 10,000 times the resolution of the old methods.
Okay, that's a massive leap in detail, from seeing the whole book to reading individual letters almost.
It really is a powerful shift, and it's crucial for those PGT-SR cases because remember, carriers of these balanced rearrangements, their embryos have a tough time. Often, only about 34% to 35% of their blastocysts are actually chromosomally normal or uploid. Accurate screening is key to finding those viable few.
Let's circle back then to PGT-M. If allele dropout is such a big risk for missing single gene errors, how do labs get around that?
Right, they can't just rely on detecting the mutation directly because of the ADO risk, so they use a clever workaround called haplotyping analysis.
Haplotyping. Okay.
Instead of just looking for the specific mutation, they analyze the genetic neighborhood around the gene. They look at a set of unique genetic markers, like little signposts that are located near the gene on the chromosome. By looking at the pattern of these markers, they can figure out which chunk of chromosome, which parental haplotype, the one carrying the high-risk gene, or the one carrying the normal copy, the embryo actually inherited.
Ah, okay. So it's like using nearby landmarks to confirm your location, even if your specific house number is hard to read on the map.
That's a great analogy, yeah. It adds a layer of confirmation, but it's not simple. It requires quite an intensive preclinical workup. They need DNA samples from the parents and often other family members like affected children or grandparents to figure out which markers are informative for that specific family before they can even start testing embryos.
Right. It's personalized detective work beforehand.
Exactly.
Now, let's touch on maybe the most ethically charged application of PGT-M, using it for HLA matching, the whole save your siblings scenario.
Yes, this is definitely high stakes. HLA stands for human leukocyte antigen. This is when PGT is used not only to ensure an embryo is free of a particular genetic disease, maybe like beta thalassemia, but also to check if that embryo is an HLA tissue match for an existing sibling who is suffering from that disease.
And the goal is?
The goal is usually to use stem cells from the new baby's umbilical cord blood at birth to treat and potentially cure the older sick sibling.
Wow. The chance of finding an embryo that's both disease-free and an HLA match must be quite low sometimes.
It can be very low, yes, which means potentially screening many, many embryos. And this immediately raises profound ethical questions.
Yeah, I can see that.
The core concern, ethically, is the potential for the resulting child to be viewed primarily as a means to an end a biological resource or a tool to help the sibling, rather than being valued entirely for their own sake. Plus, there's the difficult counseling around what to do with healthy embryos that are genetically fine but just don't happen to be the right HLA match. It's complex.
Immense ethical weight there, no question. Requires incredibly careful counseling. Okay, let's shift gears now from these very specific targeted applications preventing known diseases to PGT-A, the broad screening test. The most common one, you said, but also the most controversial. Who is PGT-A usually recommended for?
Typically, PGT-A screening for those aneuploidies is offered to couples facing certain challenges. Things like advanced maternal age, AMA, usually over 35 or 37, or couples who've had recurrent implantation failure, RIF, meaning embryos transferred but not sticking, or recurrent pregnancy loss, RPL, and sometimes for severe male factor infertility as well.
Okay, so the big question then, does it actually work? When you look at the large studies, the randomized controlled trials, does PGT-A increase a couple's overall chance of ultimately having a baby from their IVF cycle?
And this is precisely where the controversy explodes. The broad consensus from major bodies like the American Society for Reproductive Medicine, ASRM, is pretty clear. They state that the value of PGT-A as a routine screening test for all IVF patients, well, it has not been demonstrated. Multiple large, well-designed trials, these multi-center RCTs, have consistently found that the overall cumulative live birth rates, CLBR, are statistically similar between cycles using PGT-A and cycles using traditional IVF methods without the screening.
Wait, let me make sure I understand that, because it sounds huge. The cumulative live birth rate, that's the total chance of having a baby from all the embryos created in one egg retrieval cycle, right?
Correct. Whether you transfer them fresh, frozen, one by one, your total success potential from that batch of eggs.
So if the CLBR is the same with or without PGT-A, It means the test isn't actually increasing the ultimate success rate. So why do it? Why add the cost, the biopsy risk, and critically, as we'll get to, the chance of discarding usable embryos if the final outcome is the same? It's just about speed.
That's the crux of the argument for PGT-A. It's about efficiency. While it might not increase your total odds from that cycle, PGT-A does significantly maximize the chance of achieving a live birth per single embryo transfer. Because you're preferentially transferring the embryo deemed chromosomally normal, your odds for that specific transfer succeeding are higher. It also generally reduces the rate of miscarriage, especially in women maybe aged 35 to 40.
Okay, so it potentially gets you to a successful pregnancy faster, with fewer failed transfers and fewer miscarriages along the way.
Exactly. It shortens the time to pregnancy. And for patients who've been through multiple failed cycles or heartbreaking losses, reducing that time and emotional stress is, well, it's incredibly valuable. For many patients in clinics, that efficiency is the main goal.
That efficiency argument leads us directly into what seems like the most difficult, maybe agonizing problem in the field right now: mosaicism.
Oh, the mosaic problem is huge and really complex. Mosaicism is when that tiny biopsy sample from the embryo shows evidence of more than one distinct cell line, chromosomally speaking. So some cells might look normal, euploid, but others look abnormal, aneuploid. It's not a clear yes-no result.
It's mixed.
A mix. And how often does this happen? Reports vary, but studies suggest mosaicism rates in blastocysts are somewhere around 15%, maybe up to 17% or even higher. But here's the tricky part. Diagnosing it is subjective. Different labs, different technicians, different platforms, they can interpret the data differently. The reported rates of mosaicism can vary wildly between clinics, sometimes by as much as 30% based on their thresholds.
Wow. So the diagnosis itself isn't even consistent.
Yeah.
And the uncertainty for the patient must be immense. What do you do with that embryo? Transfer it? Discard it?
Exactly. And the clinical outcomes data just adds another layer of complexity. Yes, studies show that embryos classified as mosaic do have a higher rate of miscarriage compared to embryos classified as fully euploid. That makes sense. But, and this is critical, we now have a growing body of evidence showing that infants born after the transfer of mosaic embryos appear to be generally healthy, similar to infants born from euploid transfers.
So the mosaicism can resolve. The embryo can self-correct during development.
It seems that way in many cases, yes.
Yep.
The abnormal cell line might get outcompeted or might be confined to the placenta and not affect the fetus itself, which leads to this really uncomfortable possibility.
That we might be discarding perfectly viable embryos right now.
That's the heart of the debate. Are we throwing away embryos that could have led to healthy babies simply because our current diagnostic tools flag them as mosaic, as ambiguous? Are we prioritizing the speed and certainty of getting a perfect euploid transfer over the potential viability of these mosaic embryos? It's a major ethical and clinical dilemma.
Okay, before we dive deeper into the ethics, let's quickly cover safety. Does the biopsy itself, taking those few cells, harm the embryo or cause problems down the line?
The overall evidence, looking at obstetric outcomes, neonatal health, early childhood development, it's generally reassuring. Most data suggests that the blastocyst biopsy itself doesn't significantly alter the risk of major adverse outcomes compared to standard IVF without PGT.
Okay, that's good.
However, it's not entirely without potential flags. Some studies have pointed towards a possible small increase in the incidence of certain pregnancy complications, specifically preterm deliveries or maybe preeclampsia, potentially linked to the trophectoderm biopsy itself. The data is still evolving there.
Interesting. And there was something fascinating about combining PGT with frozen embryo transfer, FET.
Yes, this was a really powerful finding from large cohort data looking at the SART registry in the U.S. It showed that when you combine PGT with a subsequent frozen embryo transfer cycle, so you biopsy, freeze the good embryos, and transfer later, it significantly decreases the rate of very preterm births, those before 32 weeks. This decrease was seen compared to both fresh embryo transfers and frozen transfers done without PGT.
So it suggests a kind of beneficial additive effect, selecting the best embryo chromosomally and transferring it into a more optimally prepared uterine environment in a frozen cycle.
Exactly. It seems that combination offers the best chance of avoiding those really high-risk early deliveries.
Looking forward now, is technology getting better at solving some of these issues, like the ambiguity of mosaicism or that allele dropout problem?
There are definitely exciting advancements on the horizon. One area is RNA-based PGT. Instead of just looking at the DNA sequence, it analyzes mRNA transcripts, basically, which genes are active in the embryo. This approach might give insights into embryo competence beyond just chromosome number, and some studies suggest it could achieve higher accuracy for detecting specific mutations, maybe up to 95%, potentially helping with the ADO issue for PGT-M.
Moving beyond just the genetic code itself,
Yeah.
what else?
We're also seeing the integration of epigenetics, the layer of control on top of the DNA sequence. New tools are emerging that use things like preimplantation DNA methylation screening, PMS. They look at methylation patterns, which influence how genes are expressed. The idea, often combined with artificial intelligence, is to use these patterns to better predict an embryo's likelihood of resulting in a live birth, adding another layer to help select the best embryo beyond just chromosome counting.
Fascinating. A whole new dimension of embryo assessment, potentially. Okay, let's bring it back finally to the ethical and legal landscape. The big debate seems to be about scope creep, right? Where should PGT stop?
Yes, that's a fundamental ongoing discussion. Should PGT be limited primarily to preventing serious, typically childhood-onset diseases, like in PGT-M or PGT-SR? Or is it acceptable to expand its use for adult-onset conditions, like screening embryos for BRCA12 mutations, which increase cancer risk later in life? Or even screening for Huntington's disease, which manifests much later. And then there's the even more controversial idea of using PGT to screen based on polygenic risk scores, calculating an embryo's predisposition for complex conditions like diabetes or heart disease based on multiple genes. That remains highly contentious due to, frankly, uncertain accuracy and the fact that these scores often only indicate a small increased risk, not a certainty. The ethics of discarding an embryo based on that are really complex.
And how is this regulated around the world? Is it consistent?
Not at all. Regulation is really a patchwork. Some countries have specific laws, public statutes governing PGT use. Others rely more on professional guidelines from medical societies, sort of private regulation. But one common thread you see in most places that do permit PGT is a restriction, often an outright prohibition, on using it for non-medical sex selection.
Right. Choosing the sex of your child for social reasons is generally frowned upon or banned.
Correct. However, there's some worrying data emerging. A look at the U.S. SART registry, which tracks almost all IVF cycles. It found that IVF cycles that utilize PGT for any reason, whether it was PGT-A, M, or SR, resulted in a statistically significant skew in the sex ratio of babies born. It was about 115 males born for every 100 females.
115 to 100, compared to what normally?
Compared to about 105 males per 100 females for IVF cycles done without PGT, which is close to the natural ratio.
That's quite a skew towards males when PGT is involved. What does that suggest?
It strongly suggests that, even if not the primary stated reason, sex information gleaned from PGT is influencing embryo selection decisions in some cases, leading to this imbalance. It raises real questions about utilization bias and whether regulations are truly effective in practice.
Which underscores the need for really good counseling.
Absolutely critical. Genetic counseling before and after PGT has to be incredibly thorough, balanced, and non-directive. Counselors need to carefully explain everything: the significant financial cost, the real possibility that a cycle might yield no transferable embryos, the inherent risk of misdiagnosis from things like ADO, and of course, the enormous complexities and uncertainties surrounding those mosaic results we discussed. Patients need to understand the limitations just as much as the potential benefits.
This has been an incredibly insightful deep dive. So to try and synthesize, PGT-M and PGT-SR seem like well-established paths for families facing known serious genetic risks. They offer a way to prevent disease.
Right. Their role is pretty clear in those contexts. PGT-A, on the other hand, it's definitely an efficient tool. It helps select embryos most likely to implant quickly, reducing miscarriages and the time it takes to hopefully achieve a pregnancy. But we have to be honest and acknowledge the evidence. It hasn't been proven to increase the overall cumulative chance of success for every single patient going through IVF.
And its use is really complicated by those technical limits, the amplification issues, the difficulty seeing tiny rearrangements, and most pressingly, by the ethical and clinical challenge posed by mosaic embryos. So, connecting all these threads, considering the drive for efficiency in the clinic, the shorter time to pregnancy that PGT-A offers, but also knowing, based on growing evidence, that many mosaic embryos can and do result in healthy babies, it leaves us with a really provocative question for you, the listener, to consider. Is the current quite widespread use of PGT-A and the resulting decision, in many cases, to discard potentially viable mosaic embryos, is that an acceptable trade-off? What are we as a society and what are couples prioritizing more in the fertility journey? Is it maximizing the potential health and life of every single embryo created? Or is it optimizing for the speed, efficiency, and reduced emotional burden of the patient's path to pregnancy?
A tough question with no easy answers, as this technology continues to push the boundaries of selection and intervention.
Something important to mull over. Thank you for joining us for this deep dive.